defined. So data acquisition challenges that we faced and how did we circumvent that. Then annotation team, then the models per se, and active learning, model correction, finally interpretability as to how we see a model or how a data scientist sees it, and finally model drift and continuous improvements. So this is the overall out layer of what is going to be discussed. So why radiology? So we know for a fact that radio is in the forefront of AI in medicine. The same work can actually applied. So what we discussed today can actually be applied across multiple subspecialties of medicine. So after that, actually, you have n number of solutions popping up when it comes to the field of critical care or emergency. That generates a lot of data in the form of numbers and lab values. Followed by we have ophthal, wherein there are numerous images, may it be like something like a fundoscopy or a FFA set of image, which again has a ground truth, which is a report. And also we have dermatology, wherein the lesions can be captured, photos can be taken of it, and diagnosis or HP reports can also be matched. What's common between all these branches is that they possess structured data. That is, for every stack of image, there is a ground truth. And only based on that, only if we have these, can we go ahead and think of building models. So we have critical care and emergency medicine. Finally, we have ophthalm and dermat. So these are considered as the low-hanging fruits in radiology. So any patternable problem that you come across in your field can also be templatized. And if there is structured data, you can definitely consider going ahead and building models around it. So going further, yes. So what is a good problem statement? We as clinicians must know the entire grasp of things so as to choose the right problem. So the entire model bases on this. So let's say we have two niche problems, something, okay, I'll be talking about from the radiologist perspective for today. So let's say if a radiologist is given a problem, something around X-ray and another around MRI, the default instinct is to choose something in and around MRI because that is a little peppy and fancy. So chest X-ray detection tool is low. So this is something, let's say a fracture detection tool or a lung nodule characterization tool. So this is something that can have a greater impact. Why? Because there are more number of people opting for this. And then building tools around it is more feasible as compared to an MRI, which costs upwards of 9,000 rupees. So what is more feasible is something that we have to consider about. So there's this standard jargon when it comes to analgesic versus vitamin. So something that solves a huge problem in the entire process would be an analgesic. What is a vitamin? Vitamin is a good to have tool, but can you do without it? Definitely yes. So we have to concentrate on more and more of analgesics and not more and more of vitamins. So vitamins is a good to have kind of a tool. So we have to chase a problem that genuinely has a clinical impact, and that is not something that is very niche. There's this fancy problem trap. So hard to crack problems, resource intensive problems, these might not deliver impactful solutions. So focus on real life, less glamorous kind of problems, which are ubiquitous. It's there everywhere, and that needs to be solved. And make sure we are more on doctor augmentation rather than doctor replacement protocols. Next, know your users. So, whom are you building this for? Are you building this to educate the patient directly? Or are you building this to add value to the patient directly? Know the end users. This matters a lot. Or are you building a tool for your very fraternity, wherein you need not take it to the basic most aspects? It has to save a few hours of their day. So that is so knowing the end user also helps a lot. So the value, the adjunct tools that save hours have way more superiority as compared to that attempt and fail in achieving clinical perfection. So less fancy the tool, more impactful it will be. So always chase analgesics and not vitamins. It does not end there. Feasibility. So there must be good amount of data available to solve the problem. You must have the necessary computational resources. Suppose you plan on doing something around 3D and 4D. The computational resources
This
required to
meeting
solve
is being recorded.
Yes. So the computational requirement to solve such a problem exponentially increases. And finally, it must be scalable. So these are the things that we have to keep in mind before we get into solving the or choosing the right problem. So this led to some new learning when it comes to us. So we never thought of it to begin with, and then we learned this eventually during our course of evolution. So it's been around 24 months now, and we've been fortunate to get few really valuable learnings over the period. So there has been tremendous efforts in building tools in and around medical and surgical oncology. Even though there is some good progress in areas like breast, prostate, all of that, head and neck malignancy has been a tough nut to crack. Why so? That is what we have like retrospectively learned. Why so? Because oncology and medical imaging AI tools in and around, let's say, head and neck cancers, it's always a challenge and it's not easily solvable a problem. Human anatomy varies significantly from one patient to another, so making it very difficult for AI to pattern or interpret it. So there are a lot of anatomical variants. This is one. Next, spectrum of presentation. Early cancers present in a different appearance, and advanced malignancies appear in a very different way. May it be hemorrhages, necrosis, infarcts, all of these are seen within the tumor when it is an advanced stage. So the appearance has a wide spectrum. This adds another layer to complexity. Third, inconsistent morphology. Let's say we have two cancers, HPE proven, same histopathological, same staging, but they can appear entirely differently when it comes to radiology. So all of these layers make it really hard for few problems for AI to handle. So given today's day and age, onco is not something that can be very reliably taken over by AI and still needs onco radiologists to handhold it at every point. So this is something that we learned over the period. So what is the solution? I am basically a musculoskeletal as a tool that we've built called as OsteoCheck. So what does OsteoCheck do? Here we have a 58-year-old postmenopausal female coming to us with knee pain. So what our tool does is it looks for joint space reduction, it looks for osteophytes, marginal sclerosis, if there are post-op implants, how is the soft tissue collectively grades the given case across Albrecht's or Kelvin-Lorentz grading system across the degenerative osteoarthritis. And it does not stop there. It will also give a very conducive inline continuous report as to how the findings are. So this is a solution that we've built and has been lauded, right from patients to orthopods who have been using it and to even pharma companies who've shown significant interest in it. So let's fragment it and understand it from a student of data science perspective. So how does this work? It's a pipeline. So we've built a very effective pipeline which has two main steps. First stage is a convolutional neural network model which identifies the abnormality to precision. Second stage, a large language model converts these findings into a relatable, acceptable, internationally accepted nomenclature kind of a radiological report. So the problem has two steps to the solution. Now, further, actually, the vision problem, the CNN problem was fragmented further into two parts. One being reduced density or normal density of the bone. Second, the actual degeneration grading. So this is how we've fragmented it. So today's talk, I'll be focusing mainly on the computer vision and not more about the large language models. So to the newbies out here, for the ones who are not familiar with the concept of computer vision, this would be an oversimplified parallel relentlessly, one after another. It keeps refreshing at a very sub second, like a few milliseconds, it keeps refreshing. Let's say it keeps looking out for a car in the front, a man in the front, or let's say a signboard in the front. So it just keeps looking for the signboard back to back. As long as there is no signboard, not an issue. The moment it spots a signboard, it goes back to its database, compares it as to what this signboard could be. And the moment it detects that the given signboard is matching that with a stop sign, the braking systems get activated. So this is oversimplified generalization of computer vision when it comes to cars, self-driven cars. How can we apply the same to radiology? The solutions are always looking out, watching out for a lesion. This is a mammogram. The moment it spots a lesion, it goes back to its database and starts comparing it with the entire trained model. And finally, the moment that the model says that this has speculated margins, this could be a neoplasm, it is flagged as something that needs attention. So this is how oversimplification of the entire process is. But let's get to each of it in depth, right? So first thing, data acquisition and Indian set of challenges. So we have huge data done across multiple centers, but the greatest challenge when it comes to India is that we have a dual slice, two slice CT to a 512 slice state of the art machines. We have a zero point 0.3 or an open core MRI to a 3 Tesla state of the art machine. So this huge variation in data makes it really hard to build reliable models. This is one. Second, the wide spectrum of equipments leads to variation in the quality of the images also, right? And then comes technicians. Not all center deploy trained individuals. They are just not qualified. They're just trained. These are the people manning these machines. So there are n number of artifacts adding layers to the problem. And finally, when all of these put together in scale, bring makes the model very confused when it comes to data acquisition. That another beautiful learning due course was that this spectrum of inhomogeneity is absent when it comes to Western population. So Western solution that claims stellar accuracy, precision, and recall very underperformed with Indian data. Whereas it was ulta. Indians claimed, let's say, upwards of 90, proved 95 plus accuracy when it comes to Western data because of inhomogeneity. So this data is also something that we have to look at. This is one. So it is craft for India and conquer globally. This is something that we got through during the process. Next, annotation. So next, now the ideal people to annotate and train the model would be doctors, but more often than not, doctors are limited. Their time is limited, and we'll have to resort to the next best option out there. It could be paramedics or it could be biomedical engineers. No matter who they are, the onus is on us to make them understand the process beyond reasonable doubts. So, how can that be made? So, we had a team of biomedical engineers. We had a sample size of the training set that we used was approximately 80,000 knee x-rays. So, and we had an annotation team of upwards of 40 to 50 people. So these people where this is where we as doctors come into the major role. The crux of building the model lies in how better we communicate with them, how better they understand the concepts, because at the end, it is a reflection of what we intend to do, right? So we'll have to teach them. So what is the best way to teach? Just like how deep learning is alien to us, so is medicine to them. So we held on to a few very basic rules. So that helped us immensely. Before these rules, we were actually here or there, but the trajectory of the company changed when these phenomenal rules will be abided by. We held on to ELI 6. What does ELI? Explain like I am a 6-year-old. Absolutely no jargons. May it be medical, may it be deep learning jargons. So that is when all of us are concept oriented and not jargon oriented. So that is precisely what has helped me, thankfully, to understand the concepts better. We meet midway. And the best part is you have to binarize medicine. So if we can crack this, I'm pretty sure we can actually. So what is binarizing medicine? So if we talk, let's say we have to decipher this X-ray. There's a mass at the junction of hilum and the lungs, right? So this could be a mediastinal mass, this could be a lung mass. To explain what this could be, I can go on and on, talk about n number of radiological signs, talk about a hilum overlay sign, hilum convergence sign, and all of these high sounding jargons to them, but that'll take them nowhere. How about you go to the depths of it and then come up and tell them that you measure. So based with the lung as base, you measure, or with the mediastinum as base, you measure the angle that the mass is making. If the angle is obtuse, it is arising from the same structure. If the angle is acute, then it is arising from the opposite structure. So that solves the entire problem for them. So wherever there is patternable solutions, you have to think like a data scientist. And this binarizing medical concepts will make you an excellent product manager. This has made a significant difference. And eventually, we understand their thought process. The more models you build together, the better you communicate, and they'll be really good at medicine. That is what we've seen. So, again, a beautiful learning through course. So, we've done, so one of the very first projects, we looped in one of the stalwarts, the best out there in each of the field. We looped them in and did a project. All these stalwarts were given a few set of annotators, but the result was not great. Later, we just had one or two SMEs, subject matter experts, but the results were phenomenal. What was the thing that differed? The thing here out there is it's like too many cooks spoil the broth. So too many people involved, especially subject matter experts, more the inter observer variability. So coming back to this part again, so there is you must avoid refrain from telling I feel, I think. So there has to be objectivity brought into every bit of the model, so that it must not be subjective. But then, since that we're dealing with medicine here, we really can't be sure, and it's not. So it's rightly said in medicine, always and never is always never correct when it comes to medicine. So we do encounter, we do get to crossroads. It is better to omit that when model training just to avoid confusion in the pen model to increase accuracy. So yes, so this was a very important observation that solutions having lesser number of SMEs did well as compared to many subject matter experts in a given project. Why so? Because no matter the model is wrong or right, it might call something wrong, but it is consistently calling it wrong. That matters to us. But if it is confused, if one person says the same thing is right, the other person calls it wrong, that is when the model gets confused. So, well, while it comes to model training, lesser the better. We can actually go back and rewire it in days to come. Right? So for the sake of completion, what have we used? When it comes to 2D imaging, we've used Label Studio, and when it comes to 3D, we've used V7 Labs. I'll skip this part. So coming to the AI pipeline proper. So yes, I'll just take 5 more minutes to wind up. So yes, what are the things that we do? We do segmentation first, and then we crop the images. Then we do classification, object detection, and grading. Let's get to each of these in a very crisp manner. So what is, so these are all the available options out there. What is classification? Identifying whether an image is normal or abnormal. Classifying involves assigning a label to an entire image per se, determining whether it belongs to one or several predefined categories. So the architecture that we know of is ResNet, DenseNet. Then we have object detection, wherein the output is not just a class, it is also a bounding box, class plus coordinates, right? That is object detection. Where do we use this? We use it in tumor detection, bleed detection, lung nodule characterization, places like these. So this object detection can be single stage or two stage. Single stage is you look only once, or two staged is when we're talking about RCNN, faster RCNNs and stuff. Finally, you have segmentation, wherein the entire image is pixelated and each pixel is classified. It goes back into plus or minus. So we have all these tools. How did we get started? We took the entire X-ray, and first thing was to identify the knee X-ray, right? So we classified, cropped the entire thing using a segmentation model. Only the distal femur, the patella, uh, proximal tibia, and the fibula were taken, cropped. So segmentation tool did that for us. After segmentation, we used classification models, wherein joint space reduction is present or absent. It's a yes or no question. We've used DenseNet and Vision Transformers to be doing this. Moving on. Finally, it is object detection again. Not just that, we also went forward to talk about osteophytes, post-op changes. All of these changes where object detection came out with a bounding box. Let's say you've done all of these, you've used all the tools rightly. What do you do next? You feed this into the model, right? You had, let's say, 100 images. You divide it into train set and test set. You annotate the train set, you give it to the model, it will do a few errors. That is when we have to intervene in between and tell where there is a problem. The annotators re-annotate and help it gradually. This is called as active learning. So in the active learning phase, initially we began with somewhere around 86%. We hit a 98% in the 4 months after iterating it with multiple epochs. So this is in loop. And finally, so this bounding box is how we understand it as doctors, right? How does the model or computational engineers understand it? It is through GradCam. So there are heat signatures. This is how the model is trying to understand it. So same story in two different angles. So if there is a heat signature, it is how the model is trying to make sense of it. Finally, we do something called as model drifting. So what is model drifting? It's like a post-marketing surveillance when it comes to pharmacology. So, model drifting is when you've deployed a very highly accurate tool with very good precision and recall, but then there's a high probability of this tool drifting away from the expected accuracy. In that case, you add test and train sets in a stipulated period of time and retrain it and put it back into active learning phase whenever there is a drift noted. This also must be done repeatedly. So this is what if finally coming up to. So recap, you have to find the right problem. Data challenges is always present. Have a clarity when it comes to pipeline. Talk to annotate people. Then train the annotation team. They must be your representatives. Active learning will happen. And finally, interpretability. So doctor should lead and not just be involved. That is my shout out here. Always search for analgesics and not vitamins. Now is a great time to go ahead and not just be co-authors. We have to try to be co-creators when it comes to intellectual property rights. Where do we find? We have all the subject matter expertise that we require. Where do we find people to build models? I would suggest LinkedIn to be a great place to start with. So there are a lot of people yearning to get started when it comes to medical fields. You can just reach out to them or just post it out, and it's all yours. Sorry if I've overshot my time. There's enough
That's
and more
perfectly
to
all
do.
right.
Yes.
Thank you so much. So it was very insightful as well as so layered that you simplified such difficult and complex terminologies that are used in AI and LLMs. Thank you so much. Uh, there are a few questions, audience questions coming in, but I'll quickly pitch in one of my questions.
Sure,
Is
man.
um like I need to understand so there is so much diversity in the infrastructure in
True.
India. So
Yes.
how do you is the annotation protocol scalable in tier 2, tier 3 cities, or do you like recommend having like a decentralized, more federated approach to the whole situation?
No, madam. I would actually strongly endorse centralization because more the spectrum, the better. We need not actually build models into only the niche 3 Tesla models or niche 512. So, wider the spectrum, the more robust the model building is. So, and after a point, it really does not matter as to what the, let's say, the clarity of the image is.
Okay.
So, but initially it does. Where does it matter? When you're cleaning the data. If it is not interpretable, so that has to be just chucked out. So the ones that go into the bin are most probably from these lower tier 3 cities. That is an observation that's practically out there.
Thank you so much, sir. Dr. Himin asks a question about how do we ensure the transparency and explainability in AI driven diagnostic suggestions?
Explainability, yes. Transparency, I'm not able to understand the exact question as to what the doc meant. But explainability, yes, definitely. So that is where bounding boxes or heat grad camp signatures come into play. So so you can actually explainability can be taken into in different ways. Actually, that by itself is a talk for half an hour. Explainability in AI, but I'll just attempt to address that in a very crisp minute or two. So there's no end to how much you can take explainability to, right? So transparency, I think you're talking about. See, at the end, AI is a black box. What happens inside is not something that we can very precisely talk about. Yes, that is a given. But uh, given that transparency, I'm not very sure of what the doc meant on it. But explainability, you have multiple matrices to evaluate how good it is.
Mhm.
And as we rightly said, you can integrate LLMs and transformers to actually convert whatever the given interpretation is to in a desired format, which is very easy uh, in R. So you just have to build an encoder and decoder, and that will act. So getting the desired output format is very easy.
Okay. I think that's how much the time is going to allow us for this discussion. I hope we keep continuing this discussion over our WhatsApp channels that are available in Doctors AI community. Thank you so much, sir. I especially appreciated the whole very tech heavy, but very easily interpretable for all the student doctors here. So thank you so much for keeping the conversation quite crisp and for answering all the questions. Thank
Thank you
you.
so much, ma'am. I'm very open to taking questions even on the
Sure.
community or personally.
Yes.
Thank you so much again.
Thank you. We move ahead for our next speaker for this session, Dr. Rameshwar Kumar sir. Hetwi, if you could please help me with the CV slide. Thank you so much. Dr. Rameshwar sir is an accomplished orthopedic and joint replacement surgeon with over 18 years of clinical experience and a strong interest in medical innovation through AI. He's done his MCH ortho from Seychelles University. He's a professor at KMC Medical College and a mentor to medical students, residents, and fellow in orthopedics and AI applications. He's performed over 20,000 orthopedic surgeries, including 1,000 plus joint replacements. He's a pioneer in non-surgical knee pain management via the MP ritual and developer of AGPT, a custom GPT model for orthopedic workflows. He's a developer of AI-powered educational and clinical decision tools, creator of digital health content, and personalized coaching via AI. He's an expert in GPT, Perplexity, Claude, Orange, Volt. Thank you so much, sir, for accepting the request to be talking to us. He's also a founder of Sri Sai Hospital in Sivan, first NABH certified 100-bed multi-specialty hospital in the region. He's published multiple research papers in orthopedic innovations and AI integration. He's won quite a few awards, Sivan Ratna Award, Chikitsa Ratna Award, Best Paper Gold Medal in Indian Orthopedic Association Award, and much more. I welcome you, sir. Thank you so much for accepting our invitation to speak to all the young doctors. Over to you.
Thank you, Aishwarya. Thank you for this beautiful introductions. And I just say PPT first.
Yes.
Dr. Aishwarya and all the listeners right here, I am here to present over the use of artificial intelligence in orthopedics and robotic surgery, the latest developments, what is there. Myself, Dr. Rameshwar, I'm an orthopedic surgeon based in Bihar. And thank you, you peoples, for giving me this opportunity. Before I start my presentations, there are three latest development that has uh, given excitement to me and that I want to share to you all peoples. Elon Musk recently announced that artificial intelligence based robot will outperform surgeon in coming 10 years. Bill Gates recently has told in one of his podcasts that AI will replace doctor in coming 20 years. And recently, China has launched one fully AI hospital treating more than 14,000 patients per day. And this is really a thought-provoking things that is there AI is going to replace doctor? This is the question in my mind. And through my journey and my presentations, I will like to give answer to all these questions, whether these facts are really true and what are the truth behind this. Actually, I am able to know about this generative or artificial intelligence. Frankly, I am telling when ChatGPT was launched. It's about one and a half year back, and that was a really fascinating things when I asked ChatGPT. I just want to have one. Are you able to see me? Are you able to see? Hello,
Yes, sir.
hello.
Yes, sir. Yes, sir. We
Yes,
are
yes.
able.
Yes, I am giving a presentations on ChatGPT and the use of ChatGPT, and with me there is Dr. Praveen and Dr. Aishwarya and Dr. Srishti Shomya is there, and other listener are there in my presentations. Please ChatGPT write a poem to say thanks on behalf of me. This please do this. Listen this.
Sure, I'd be happy to help. Here's a short poem you can use to thank everyone. With heartfelt gratitude, I stand here today. To Dr. Parveen, Dr. Aishwarya, and Dr. Shrishti, I convey your presence and wisdom, a beacon of light, to all who have gathered to learn and ignite. Explore new horizons and dreams with ChatGPT's wonders and innovative streams. Thank you for your guidance, your questions, your care, for making this journey something we all can share. I hope this resonates well with your audience.
This sort of poem, this sort of creativity really ignited my mind and created a urgency for me that what AI is, and I started exploring this AI. Really, I'm telling you, before this, I was not much aware about AI, and I really shocked about its creative capability. But in medical science, creativity is always discouraged. Innovation is, I think, medical education is killer of innovation. What I think, because we can't do experiment with the patient. We have to go on the basis of what so-called protocols and everything. But in this AI, uh, in the cost of creativity, we have to prevent these biases, hallucinations, ethicals, and legal challenges. The AI must have to be transparent, safe, and explainable. Medicine does not welcome unverified creativity, and that is a challenge that I am able to learn with time. That what creativity has ignited my thoughts to learn more about AI. I think that creativity can be a threat, especially for the use in artificial intelligence, and my journey of learning started. AI is not, but when my interest regarding AI developed, then I go through the literatures and I able to know that not only this AI is not new. This AI, even in orthopedics, there are a lot of literature. Before I am aware that a lot of studies has been done, especially in orthopedics, when I able to see that regarding the use of artificial intelligence, machine learnings, deep learning, or neural networks. And this AI, when I able to go through literature, that it has been started right from the 1956 by McCarthy, and its use before the launch of ChatGPT was there in orthopedics, right from this imaging, robotics, and rehabilitations. And my real world use of AI begin with the use of ChatGPT in my clinical practice, my academic work, in the innovation and educations. What I able to see that is this ChatGPT can be a very good tools for having to diagnose or to read any X-ray, report any X-ray, which I have used practically to to support my clinical decision with the use of AI and promptings in academics to write any paper, to understand any paper, to have a review of the papers, even to write any articles, the review articles, or to review any critically review any articles whether it's good or not, to have literature review this chat GPT or all these things, even for writing books. I have used this chat GPT. Not only that, I have created my own personal assistant, my personal GPT, from where as a patient you can ask anything what you used to ask to me, and it has been trained in such a way. It used to give you suggestions. Even it used to recommend my YouTube videos if you will ask any question related to videos that I have uploaded, and if some of the videos are giving answer to your questions. In education, what I think is uh, this artificial intelligence can do wonder. What I am able to understand with the use of ChatGPT, not only to teach somebody, but to learn also, to learn something also. It's very good. I will show you some of this custom GPT that I used. I have created and I used in my day-to-day life. In creating what so called is discharge summary. CGHS guideline based discharge summary. I have created a GPT, which custom GPT, which used to create discharge summary. I have created some other tools in because I'm a YouTuber also. I used to create content on YouTube. With the use of ChatGPT, my content creation journey becomes very easy. What content I should use, what hook I should use, what call to action I should give. This all things, even to reply. You can't believe me. After learning all these things, I used to reply most of my LinkedIn's comments in such a proactive way that a lot of authority sort of people used to recognize my comments and give feedback on this comment. This chat GPT I have used in research, drafting the case report, research paper, summarizing article, planning study designs, in patient care, generating discharge summary, personalized advice. If somebody, there is a lot of my friends or a lot of my relatives used to send their reports. It's very easy to, and this is 3 page, 4 page PDF documents, and it's very difficult to read everything. I used to give it in the chat GPT, and that used to give a personalized advice, keeping the name. Hello, Mr. Hello, Aishwarya. Your report is having this, and you should do this. I used to just verify, and I used to send it. The people become very happy that Dr. Saab has given him personalized advice in in learning myself and teaching to my colleagues. Also, I have used this chat GPT in a great way. These are some of the chat GPT that I have custom chat GPT that I have created for myself to learn arthroplasty. It is my arthroplasty mentor chat GPT. It's my virtual assistant. And if you ask anything, what you used to ask to me, and regarding any problem related to orthopedics, it will give you a fairly good reply. And sometimes, if it also recommend my YouTube videos for that answer. That is, I really like this, my personal assistant. I have created the AI to learn AI. I have created this chat GPT. It step by step teach me. This is one of the chat GPT that has been developed by my wife, Srishti Somya. And in this custom GPT, if you ask anything, any problems, it will give you Ayurvedic advice that is simple, homely, available ingredients and authentic principle based upon the authentic Ayurveda principles. This is the chat GPT that has been created to create medical blog. Giving the any article, if you will give any articles based upon that, it will create a blog. And like that, for the discharge summary, I have also created some of the tools. So, in general, I have explored this chat GPT in different way, right from the social media, personal assistant, and educations. And from here, my journey of learning the artificial intelligence and use it in my day-to-day practice uh, is started. And but the artificial intelligence is much beyond chat GPT or large language models. I have used many models, and generalized model like Gemini, Perplexity, Claude, DeepSeek, Copilot, Grok, everything. But later, when I dig down, then I came across domain specific small language models, and after that I started learning. And thanks to this, my mentors and the community, I associated with two communities from where I used to learn. First is Doctor AI community, in which I really want to thank Professor Kulkarni, Dr. Dev, Dr. Anish, Dr. Alo, Dr. uh, Atul. These people are not just mentor; they become in this journey. They become my friends and other non-doctor community, which taught me about many uh, no-code tools. That is through one of the organization, Growth School, Build School, and I really want to thank the mentor right there, Mr. Prashant, Shuken, Akil, and lot of my friends right there. And in this journey, I able to dig down more deep and to some specific models that is useful for my own day-to-day practice, especially in orthopedics. The current applications of AI in orthopedics is right from pre-operative planning and training, surgical guidance, operative theaters, and operative theater assistance, which surgery to be done, how to done, what should be it and after the surgery also it predict the outcome of the surgery based upon the how surgery has been done. Even in the rehabilitations, this AI has been used right from this pre-operative planning, surgical guidance, operation theaters, predictions analysis to rehabilitations. And application of AI in orthopedics is right in the every domains, right from the trauma, sports medicines, orthopedics, oncology, spine and joint replacement or joint reconstructions. Especially the use of AI in diagnosis, X-ray, MRI interpretations. Lot of models are there in fracture detection, and also AI help in triage, early disease prediction and prioritization, so that resources can be used optimally. AI is also can be used in clinical decision support system, especially in orthopedics, and in surgery also, it work like a co-pilot to help you to guide regarding what you are doing, whether it is good or what wrong you are doing, based upon these patient characteristics, intraoperative videos, instrument kinematics, and robotic sensors. It understand using the artificial intelligence and machine learnings and give you either they can do some autonomous surgery or act like a assistant during operations to the surgeons, and in some time it gives intraoperative feedbacks regarding your skills, where you are doing wrong, what need to be improved. And also it's help in surgical skill assessment of the surgeon also, based upon the use of artificial intelligence. The in surgery, orthopedic surgery, it is useful right from pre-operative, operative, and post-operative period. In pre-operative periods, it's help in imaging to confirm the diagnosis, the predict the result of whatever surgery you are doing, total hip, total knee, pre-operatively it can do. And it's also uh, pre-operatively it's also strategize what surgery to be done, how to be done. It's also help in clinical outcome predictions. It's also help in risk identification, which patients are having risk. It's also help in surgical planning, which implant to be, which side of implant should be used. Templating, EI based templating can be done. Intraoperatively, also it help in uh, uh, guiding the surgeons regarding the use of correct size screw, implant, or prosthesis, and also give feedback to the doctors regarding better outcome. And post-operatively, it also predict the surgical outcome, and also post-operatively, it's help in rehabilitation. There are many tools which used to do all these things, and they are not the future. They are being done right now, right at these times. The role of AI in education, what I think is really fascinating, and especially the use of AI in surgical training and stimulation is I think is the best things, because being a surgeon, from where we used to learn on the body of a live persons. But this AI give you the opportunity to have a stimulations. We can create a digital twins and that will be personalized, and that is not generalized things. You can have using this AI in surgical training, you can decrease 40% errors using VR training surgeons, and 60% faster learning using digital things, and 85% skill retention with haptic feedback can be done. So I think in surgical training, AI can be really a gift for the mankind going to be, but there are limitations that we have to understand. The data privacy, that is a very big challenges. Second is explainability. What black box issues are always there, because medical science, as a science, we have to explain. There is nothing like hidden things, and that cannot be done with this medical science, because this is not a creative field. You are dealing with the life, and the biases, algorithmic biases or data biases, that are also a very much big challenges for this cyber security. Even when you are doing continuous monitorings or something dependent on remote monitorings, in which cyber security is really a big risk. The cost, the cost factor is very big challenge, especially for adoption of these tools. Workflow, because doctor is already very much busy with a lot of things. If this streamless implementations to the workflow of whatever AI tool is not there, it is not going to be adopted, and that is not going to be helpful for the doctors. Hallucinations, that is also a very big challenges, because this is a life. You can't take chance for even one in a millions, and that cannot be accepted in the medical science. The risk of medical misinformations due to hallucinations cannot be accepted. Now coming to the questions, will AI replace doctors? Certainly no. But is having strengths in learning from the vast data, consistent performance, tireless operations, but human strength are empathy and compassion, intuition for experience and ethical judgment. And the future is doctor plus AI, that is super doctors. AI augment but not replace doctor. Uh, I used to see what will happen when really EHR will be integrated. Every clinicians, whatever treatment you are doing, is integrated to the EHR, and this EHR is integrated to artificial intelligence or some server which is being trained. It will have a lot of data, and really, the data is knowledge, and knowledge is strength. I remember one of the dialogue from this Chris movie, in which Nasruddin Shah is telling, if I can predict the future, I am God. अगर मैं भविष्य बता सकता हूँ, मैं प्रिडिक्ट कर सकता हूँ कि सक्सेस हो जाएगा, मैं प्रिडिक्ट कर सकता हूँ कि ये फेल हो जाएगा, ये टोटल हिप टोटल नी सर्जरी, देन I am a god. But AI cannot predict. AI can predict but cannot feel, touch, and understand suffering. Only human can heal and will have compassion. Uh, from the medical science, which is being transformed from evidence-based to data-based personalized treatment. One thing I want to say to all of the audience right here, one of my mentor, Ans Mehra, is very young guy. He used to tell that machine is learning and human are hooked. Humans maybe if they are not creative, they are not learning, then one day machine can become better or even uh, best than we all people. And once again, I came to the questions that started my journey of this presentation, in which three provocating statements. Elon Musk say that AI will outperform surgeon in coming 10 years. Bill Gates has told that in 20 years, AI may replace doctor. And in China, recently, one fully AI-run hospital has been operationalized. But this all things, what I used to see is more of market driven or advertisement than the fact. Even the hospital that has been operated, that has been started, AI hospital, is not to treat the patient, but it is AI patient and AI doctors. It's more to learn the AI from this AI made patients, and it's not really, they are treating the real patients. The final takeaway, let's AI handle the data. Let's doctors power the healing. AI contributions is to improve productivity, outcome, and efficiency for the doctors, but doctors' role remain irrepressible for the human connection, and the future is there in the collaborative partners between artificial intelligence and doctor. It's never artificial intelligence versus doctor. It is going to be always artificial intelligence and doctors. And doctor is going to be loop because life is precious and we can't trust AI, even if it is doing marvelous job. Thank you for this wonderful presentation opportunity. I really want to thanks Aishwarya and all the team of MedSynapse for giving this opportunity. Thanks. If there is any questions, I love to answer it.
Thank you. Thank you so much, sir, for that deeply insightful and very forward-looking presentation. Your work beautifully bridges the surgical precision with the evolving intelligence of the machines. It also reminds us that, like, even if like AI is going to enhance the data, but the human touch remains irreplaceable. So I have a question regarding the robotic surgery and the AI driven template of the surgeries, that like how do you foresee the role of surgical intuition, because what happens if the anatomy deviates from the textbook norms? What, like, how does these machines intuit what needs to be done, like, next?
Actually, what I feel now, intuitions are really good, but at the same times, it is always it is based upon the small set of data. But what I think the incoming times, this artificial intelligence infusion will be supported by a lot of data, and that will be more perfect than humans or real doctors, and that is going to help doctor to have a better decisions, because the only things what I able to feel, it's my gut feeling that in coming 10 years, like C-arm is there in the operation theater of all orthopedic surgeons. It's my gut feeling that in coming 10 years, robots are going to be there in the operation theater of every surgeons, and they are not going to be like your enemy or your competitor. They are will be like a tools that is going to make you more perfect, more accurate, more productive, and more efficient. And even this intuitions has no scientific, what I feel is no scientific basis. It is always your gut feeling, or it is your small set of data from where you have taken your own judgment. But this is in the real scientific world does not have any meanings, because the things which has been supported by a bunch of data or a set of data or a lot of data is always better than just your intuitions. That's my own feeling.
Yes, definitely. There is one audience question which says, given the ethical concerns around AI hallucinations and bias in clinical decision making, what safeguards or validation frameworks do you think should be mandated before
First of all, there should be testing of this, whatever tools we are using, whether they are specificity, recalls, sensitivity, and whatever there are tools are there, the statistical tools that that must be certain, and there are many legal framework like FDA or something like that. That clearance must be there. But after all these things, human doctors should be there in loop. You can't do whatever tools is there autonomously. Doctor should be always there to verify it. Doctor should be always there in the loop. Without doctors, this AI may be dangerous.
Thank you. I think that's all the questions that we have for you, sir, today. Thank you so much. We look forward to seeing all your other innovations like AGPT, which will continue to inspire us for the next generation clinician innovators. Thank you so much, sir, for being with us today. Also, I extend my thanks and regards to Dr. Praveen, sir, for taking time out and preparing all the lectures at such short notice, and just inspiring all the doctors across the globe. Thank you so much, Dr. Praveen sir, Dr. Rameshwar sir, for being with us tonight. With this, I conclude tonight's web hour. Thank you.
Thank you for
Thank you.
having us.
Good night.
Thank you so
Thank
much.
you.